Welcome to this United States Medical Licensing Examination Step 3 review on preventive care and screening test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common preventive care question patterns you will see on your board exam, covering screening recommendations, immunizations, and lifestyle counseling, and teach you how to pick the right answer quickly. The goal is not to reteach every guideline, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the preventive medicine sections of your main review book and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for preventive care, cancer screening, and immunizations. Second, we will apply test-taking strategies built around Grade A and Grade B recommendations and the age cutoffs the exam loves. And third, we will master the next best step format for screening, vaccination, and lifestyle counseling questions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your approach so you can move fast and score points. Strategy 1 is to act on Grade A and Grade B recommendations only. The United States Preventive Services Task Force assigns letter grades. Grade A and Grade B mean the service should be offered, and these are the answers you choose. Grade C means offer selectively based on the individual patient. Grade D means do not offer it, and these often appear as tempting distractors. An I statement means the evidence is insufficient. On a typical question, a healthy patient comes in for a routine visit, and the correct answer is the Grade A or Grade B service that matches the patient age and risk factors. Match the patient to the recommendation, then pick it. Strategy 2 is to anchor every question to the patient age. The very first thing you should read in a screening question is how old the patient is, because most preventive questions hinge on whether the patient has crossed a specific threshold. The answer choices are often the same test offered at different starting ages, and only one age is correct. Memorize the anchor ages. Cervical cytology begins at 21, colorectal screening begins at 45, mammography begins at 40 for shared decision-making, and at 50 for routine screening. Lung screening runs from 50 to 80, and one-time aneurysm screening applies to men 65 to 75 who ever smoked. Let us look at 3 high-yield stems you will see again and again. The lung cancer screening stem describes an adult 50 to 80 years old, with at least a 20-pack-year history, who currently smokes or quit within the past 15 years. The answer is annual low-dose computed tomography of the chest. The colorectal stem describes an average-risk adult who just turned 45 with no symptoms, and the answer is to begin screening now. The aneurysm stem describes a man 65 to 75 who has ever smoked, and the answer is a one-time abdominal ultrasound. Recognize these patterns instantly, and you will save precious time. Let us work a practice question. A 55-year-old man with no respiratory symptoms comes in for a routine visit. He has smoked 1 pack of cigarettes per day for the past 25 years and still smokes. His examination is unremarkable. What is the most appropriate health maintenance recommendation at this visit? Your choices are chest radiograph every year, low-dose computed tomography of the chest every year, sputum cytology every year, or no screening is indicated. Take a moment to calculate his risk and decide before we walk through it. Let us walk through it. Step 1. Check the criteria. 1 pack per day for 25 years equals 25 pack years. He is 55 and currently smokes, so he meets all 3 criteria: age, pack years, and smoking status. Step 2. Apply the rule. Adults 50 to 80 with at least 20 pack years who currently smoke or quit within the past 15 years get annual low-dose computed tomography. This is a Grade B recommendation, so you act on it. Step 3. Eliminate the wrong answers. Chest radiograph does not reduce mortality and is not the screening test. Sputum cytology is outdated. No screening is wrong because he clearly qualifies. The answer is low-dose computed tomography of the chest. Here is another practice question. A healthy 45-year-old woman comes in for a routine visit. She has no gastrointestinal symptoms, no family history of colorectal cancer, and no inflammatory bowel disease. She has never been screened. What is the most appropriate recommendation regarding colorectal cancer screening? Your choices are: begin screening now, begin screening at age 50, no screening unless symptoms develop, or begin screening at age 40. Notice how the choices are all the same test at different ages. Lock onto her age and decide. Let us break it down. Spot the pattern: average risk, no symptoms, just turned 45, never screened. The single most important word in the STEM is her age. The recommendation lowered the starting age for average risk adults from 50 to 45, and this is a frequently updated, frequently tested point. Now eliminate. Begin screening at age 50 uses the old cutoff. No screening ignores an asymptomatic adult who now qualifies. Age 40 is too early for average risk. The answer is to begin screening now, with colonoscopy or a stool-based test, both acceptable options. When the choices are one test at several ages, the age is the whole question. Now let us cover adult immunization rules the boards love. Some vaccines are tied to age. Influenza vaccine is given every year to everyone 6 months and older. The shingles vaccine starts at age 50. Pneumococcal vaccination is routine starting at age 65, and earlier for adults with certain chronic conditions. Other vaccines are tied to pregnancy and risk. A tetanus, diphtheria, and a cellular pertussis booster is given during every pregnancy to protect the newborn. And live vaccines, such as measles, mumps, and rubella, are contraindicated in pregnancy and in significant immunocompromise. These rules are tested constantly, so learn them cold. Let us apply that with a question. A 28-year-old woman at 28 weeks of pregnancy comes in for a routine prenatal visit. She feels well, and her pregnancy has been uncomplicated. She asks which vaccine she should receive now to protect her baby after birth. Which vaccine is most appropriate at this visit? Your choices are measles, mumps, and rubella vaccine, the tetanus, diphtheria, and a cellular pertussis booster, live attenuated influenza nasal spray, or no vaccine until after delivery. Think about which vaccines are safe in pregnancy and which one protects the newborn. Let us walk through it. Spot the pattern. A pregnant patient in the 3rd trimester asking how to protect her newborn. The tetanus, diphtheria, and a cellular pertussis booster is recommended during every pregnancy, ideally between 27 and 36 weeks, so maternal antibodies cross to the baby and protect against pertussis. Now the key distinction. Measles, mumps, and rubella and the live nasal spray influenza are live vaccines, which are contraindicated in pregnancy, so eliminate them. Waiting until after delivery misses the chance to protect the newborn. The answer is the tetanus, diphtheria, and a cellular pertussis booster. And remember, inactivated influenza is also safe and recommended in pregnancy. Here is a high-yield pearl on children and lifestyle counseling. For the pediatric schedule, the hepatitis B vaccine is given at birth. Most other infant vaccines begin at 2 months, and the first measles, mumps, and rubella dose is given at 12 to 15 months. For lifestyle counseling, the single highest yield intervention on the exam is smoking cessation, which carries grade A support. When a STEM describes a patient who smokes, drinks heavily, or is sedentary, the correct answer is usually to counsel and offer the proven intervention, not to order a test. For tobacco, combine counseling with medication. This matters because the exam rewards prevention over reflexive testing. Let us wrap up. To prepare, review the preventive medicine and health maintenance sections of your main review book and your question bank. Drill the screening age cutoffs, the grade A and grade B recommendations, and the adult and childhood vaccine schedules until they are automatic. If you found this helpful, please like and subscribe for more board review content. And visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan and a strong application. Thank you for watching and good luck on your exam.